Assalamu alaikum. Let's dive into a very unique topic, that is urinary incontinence. Urinary incontinence, the involuntary loss of urine, is often divided into three subtypes, and that is stress, urge, and overflow incontinence. Okay, continence is mainly maintained through a combination of the voluntary and the involuntary control. So, if we draw a picture, like if you think that this is the brain, so in here, in the cerebral cortex, in here, the cerebral cortex, which is the upper motor neuron, human upper motor neuron, in here, the continence, like in here, maintains continence by inhibiting the micturition. The cerebral cortex, the upper motor neuron, maintains continence by inhibiting the micturition. And in here, in the brain, if there is interruption of the cortical input and maybe happened in normal pressure hydrocephalus, there may be bladder hyperactivity. That means urge incontinence. This one. So cerebral cortex, the problem in the cerebral cortex is the urge incontinence. I- So detrusor overactivity is urge incontinence, and detrusor underactivity is overflow incontinence. So detrusor overactivity is urge incontinence, and detrusor underactivity is overflow incontinence. And the stress incontinence happens due to decreased urethral sphincter and urethral hypermobility. So in the brain, in the cerebral cortex, in the cerebral cortex maintains continence by inhibiting the micturition. Okay, then the signal comes down. In here there is pons. We know that in this area there is pons. So PMC, pontine micturating center. In pontine micturating center, it is upper motor neuron. It coordinates detrusor contraction and sphincter relaxation. So pontine micturition center, upper motor neuron, it coordinates detrusor contraction and sphincter relaxation. And loss of PMC, pontine micturition center input, loss of PMC input happens in the spinal cord injury, thus leading to neurogenic bladder. So if there is disruption, or if there is spinal cord injury, there is loss of PMC, which leads to neurogenic bladder. And then the signal goes upwards and the signal goes downwards. And in here, S2 to S4, in here S2 to S4, it sacral spinal cord, it stimulates the bladder. The sacral, this is the bladder. I know my drawing is very bad, but you need to, for understanding this, you need some sort of drawing. So this is the detrusor muscle. This one is the detrusor muscle, and this is the external urethral sphincter. This is the external urethral sphincter. This S2 to S4 stimulates the bladder, and they gain the signal from the bladder. It goes to the S2 to S4, the sacral spinal cord, which is the L, M, and lower motor neuron. It relays signal from and to the bladder wall urethral sphincter. It relays signal to and from the bladder wall and urethral sphincter. Lower spinal cord lesion, as happens in cauda equina syndrome, as happens in the tethered cord. These can cause bladder underactivity. So detrusor uh, underactivity, which is overflow incontinence. So detrusor or bladder underactivity, which is overflow incontinence. And the another cause of overflow incontinence is bladder outlet obstruction. But if there is any lesion in the a sacral spinal cord, which is the lower motor neuron type, and it is a relay station, relays signal to and from the bladder wall and the urethral sphincter, and loss of lower spinal cord lesion like cauda equina, tethered cord leads to bladder underactivity and thus leads to overflow incontinence. So there are mainly three incontinence. We know that stress, urge, and overflow incontinence. Stress incontinence is due to decreased urethral sphincter and urethral hypermobility. Decreased urethral sphincter and urethral hypermobility. There is with leakage with coughing and lifting and sneezing, and the treatment is the stress urinary incontinence, the SUI, stress urinary incontinence. The treatment is lifestyle modification, pelvic floor muscle exercise, pessaries, and pelvic floor surgery, pelvic floor exercise, pessary, and pelvic floor surgery. And urge incontinence, the urge detrusor. Urge incontinence is detrusor overactivity, hyperactivity. There is sudden, overwhelming, frequent need to avoid lifestyle modification, bladder thinning, and anti-muscarinic drug. Anti-muscarinic drug and overflow incontinence is detrusor underactivity, constant involuntary dribbling and incomplete emptying. Identify and correct underlying cause. There is cholinergic agonist. Cholinergic agonist can be given an intermittent self-catheterization, and mixed is both stress and urge. Mixed is both stress and urge. On the first line treatment of any type of incontinence is bladder training and pelvic floor muscle exercise. Neurogenic bladder can range from bladder atony to spastic bladder. So if I tell that this is neurogenic bladder, can you tell me which center is involved? This, yes, it is pontine maturation center is involved, and pontine maturation center involvement causing neurogenic bladder to happen. So neurogenic bladder, from bladder atony to spastic bladder, but importantly, these patients would have a clear neurogenic insult like MS, like stroke. So for neurogenic bladder to happen, you need to have some clear neurogenic insult. Clear neurogenic insult like stroke, like MS. Okay. Okay, now initial evolution of mixed incontinence includes voiding diarrhea. So mixed incontinence need voiding diarrhea which tracks fluid intake, urine output, and leaking episode in order to classify the predominant type. So for mixed incontinence, you need avoiding diarrhea, which tracks fluid intake, urine output, and leaking episode in order to classify the predominant type of the urinary incontinence and determine optimal treatment. All patients with mixed incontinence generally require bladder training with the lifestyle changes, weight loss, smoking cessation, decreased alcohol, caffeine intake, and pelvic floor muscle exercise like Kegel exercise, Kegel exercise. What type of catheterization is recommended for patients with neurogenic bladder to reduce the risk of catheter-associated UTI? Clean, intermittent catheterization, clean, intermittent catheterization, like insertion or removal of clean urinary catheter every 4 to 6 hours and can be performed by a patient or caregiver. Cause of urinary incontinence in elderly. It may be genitourinary cause, detrus or contractility, and detrus or overactivity, bladder or urethral obstruction, tumor or BPH, urethral sphincter or pelvic floor weakness, and urogenital fistula. Neurogenic is MS, dementia, spinal cord injury, disc herniation. Dementia is Parkinson, Alzheimer, NPH, and the potentially reversible is delirium, like diapers, delirium, infection, like UTI, atrophic urethritis or vaginitis, pharmaceutical like alpha blocker, and diuretics, psychological depression. Excessive urine output is diabetes, congestive heart failure, restricted mobility post-surgery, and stool impaction. What is the best next step in the management of acute urinary incontinence? The patient has a history of dementia and has less active, sleeping more for the past week. Vitals are normal. Urine analysis and urine culture. Most common cause of urinary incontinence in elderly patient is UTI. Elderly patient often lack of typical symptoms of UTI, dysuria, and fever. Patient may have delirium secondary to UTI. Often infection is excluded. Additional testing can be done to rule out the other cause. Incontinence pressure is used to treat the stress urinary incontinence and symptomatic pelvic organ prolapse and anterior vaginal wall bulge. It works with stabilizing the pelvic floor in its anatomic position and compressing the urethra against the pubic symphysis. Mid-urethral sling procedure are performed for stress urinary incontinence to urethral hypermobility when pessary falls. Vaginal estrogen therapy is used in patients with genitourinary syndrome of menopause, vaginal dryness, atrophy due to estrogen deficiency. In postmenopausal patients, localized estrogen can relieve the urinary symptoms. Postmenopausal estrogen deficiency can cause urge incontinence. Stress urinary incontinence is often associated with urethral hypermobility, characterized stress urinary incontinence is associated with urethral hypermobility, characterized by urethral angle more than 30 degrees. So this is resting, this is normal, this is valsalva. So urethral angle, if characterized by urethral angle more than 30 degree. So in stress urinary incontinence, urethral angle is more than 30 degree from horizontal with an increased abdominal pressure. Q-tip test. Look, this is the Q-tip test. Stress incontinence may also caused by decreased urethral sphincter tone. If we put something in the resting position and in the valsalva position, the angle should be less than 30, but in stress urinary incontinence, the angle will be in Valsalva more than 30 degrees. That is the Q-tip test. In postpartum stress incontinence increase the risk of chronic stress urinary incontinence, but most cases are self-limited because the pelvic floor muscle and pubodental nerve heal after delivery. Therefore, less than 6 weeks of postpartum are managed with observation and reassurance, and encouraged to perform Kegel exercise to strengthen the pelvic floor muscle. So that is all about urinary incontinence. Hope you enjoyed.